Welcome to the oral cavity and anatomy and pathology lecture for the resident lecture series. There are no disclosures. So for this lecture, we will review the cross-sectional imaging anatomy of the oral cavity. We will then cover the topic of upstaging of oral cavity cancer and how us as radiologists can add value for the clinicians. We will also discuss the changes in oral cavity cancer imaging in the 8th edition of the TNM staging manual. So as we know, clinicians can see superficial disease. For example, in this case, they do not need us to tell them that there is a lesion along the right aspect of the oral tongue. The role of imaging is really to assess for deep disease extension that they cannot see or palpate. For example, submucosal disease extension, bone and perineural disease. And for this purpose, imaging and knowledge of imaging is crucial. It is imaging, for example, that plays a role in why these two different patients with tongue carcinoma are treated with slightly different surgical approaches. The top patient was able to have a resection with primary closure, while the patient on the bottom had a flap reconstruction. So let's quickly review imaging technique. So at our institution, we image patients with oral cavity disease with both CT or MRI. This is our CT protocol. We give a double bolus of contrast, as you can see here. We use 2mm collimation, and imaging extends from a level just above the orbits to the thoracic inlet, and we reconstruct in the 3 orthogonal planes. If there is dental hardware, we do separate angled acquisitions into oblique planes, as you can see here, using a lower MA. Here's an example of angled imaging and its use. This patient has an oral cavity lesion, and you can see that the dental streak artifact is causing obscuration. With angled imaging, we can see that the lesion in the tongue is now visible. We also employ puffed cheek scanning. This is especially important for lesions of the buccal mucosa. As you can see here, the left buccal carcinoma would be very hard to see if the tissue was applied to the adjacent tongue parenchyma. This is a general breakdown of our MRI technique. We like to make use of very basic T1 and T2 weighted imaging series in the 3 planes. We like to have one T2 fat-sided sequence, and we choose the axial plane at our institution. We also give gadolinium contrast to assess for any possible perineural disease. Okay, let's move on to imaging anatomy. So the oral cavity, as you can see here, is outlined in red. The oral cavity is the most ventral aspect of the aerodigestive tract. It is bounded superiorly by the palate and inferiorly by the plane of the hyoid. A key landmark is seen here in the red. We see this curvilinear delineation in the tongue. This corresponds to the circumvallate papilla, which separates the oral tongue from the base of tongue. The oral tongue is a part of the oral cavity, and the base of tongue is part of the oral pharynx. As you can see here, there are many subsites and components to the oral cavity, including the oral tongue, the buccal mucosa, the bony jaws, and the sublingual space. One of the main components of the oral cavity is the oral tongue, which is composed of 4 paired intrinsic and extrinsic muscles. The intrinsic muscles play a role in changing the shape of the tongue for the act of eating and swallowing. The intrinsic muscles include the longitudinal, transverse, and verticalis muscles. In terms of imaging, the 2 muscles which we see often and easily are the superior longitudinal and the transverse muscles, as delineated on the MRI scan. You can see them on the sagittal images as 2 curvilinear bands of tissue. The extrinsic muscles are those 4 paired muscles with external bony or ligamentous attachments. They include the genioglossus, styloglossus, hyoglossus, and palatoglossus muscles. It used to be that tumor invasion of these muscles in both oral cavity and oropharyngeal carcinoma would upcategorize patients to a T4A level. This is no longer the case for oral cavity. It is still important, however, to assess for tumor involvement of these extrinsic muscles. For example, at our institution, some of the surgeons will use extrinsic muscle involvement as a factor when they are deciding upon the need for a flap reconstruction. So now let's look at these muscles on this coronal MRI. At the very top, we can see the superior longitudinal muscle. Centrally are the two prominent genioglossus muscles. Laterally are the hyoglossus muscles, and below the genioglossus is the geniohyoid muscle. Here is the mylohyoid that forms a sling holding up the tongue. The anterior digastrics are paired below the mylohyoid. Here are the bilateral sublingual glands situated lateral to the genioglossus. And here's another important structure. You can see the flow void of the lingual artery. Let's see these structures now in the axial plane. Again, starting centrally, the paired genioglossus muscles. Just lateral to them, once again, are the smaller hyoglossus muscles. Lateral to them, we see the cut margin of the mylohyoid muscles bilaterally. And here is the sublingual gland and the submandibular gland. So a quick word on the sublingual space. We've already seen it. It is that space lateral to the genioglossus muscle and above the mylohyoid. It contains the sublingual gland as well as 3 of the 4 extrinsic tongue muscles. So if we were looking on the axial plane, the yellow here on this slide outlines the sublingual space. Another component of the oral cavity is the mucosa of the floor of mouth, here highlighted in blue. This mucosa extends from the anterior tonsillar pillar on one side, extending across midline to the contralateral anterior pillar. So again, this mucosa covers the lingual alveolar sulcus. And here it is on a coronal CT scan. You can see the blue arrow highlighting the mucosa of the floor of mouth on the left, and on the right we actually see a carcinoma involving the right floor of mouth mucosa. Another component of the oral cavity is the retromolar trigone. This is that portion of anatomy that runs along the ridge of the mandible posterior to the last molar. You can actually see it here on this clinical image noted by the asterisk in blue. An easy way to find the retromolar trigone on imaging is to look at that point where the buccal mucosa joins the tonsillar pillar. As you can see here, we can find the buccal mucosa and run backwards. We can find the tonsil and run forwards, and where they join at the point of the arrow, this is the retromolar trigone. The arrow shows a retromolar carcinoma on the contralateral side. Okay, so what are the specific things that we as radiologists need to assess in terms of tumor staging in the oral cavity? Again, we can see, or we've seen, that the clinician can see superficial disease. So for example, when they look in the oral cavity, they will be able to appreciate the mass-like prominence related to this mass. What imaging is important is to show the deep extent. So for example, neurovascular structure involvement as well as bone involvement. This slide shows the various subsites, and going forward we're going to review and have a look at some of them and talk about some of the key imaging features we need to assess. So starting off with the lip. So lip carcinoma accounts for 40% of oral cavity cancer. Most arise along the vermilion border of the lip. Superficial disease or very small superficial disease is usually not imaged. For larger lesions, however, we do need to carefully assess the status of the adjacent bony mandible. This arrow, as you can see here, shows a typical localized lower lip carcinoma. This patient has a larger lip carcinoma, and it's done with a puffed cheek imaging technique, so we can see that the labial alveolar sulcus is actually clear, and hence the bone is clear. So this is a very important finding to distinguish. Cancer can also arise along the gingiva as well. Rarely it can arise from within the alveolar bone of the mandible or maxilla. One thing we need to note is that very superficial bone invasion by a gingival primary is not considered T4 category disease. For disease arising in the gingiva and alveolus, bone involvement is very important to document as it can affect surgical approach. For example, depending on the extent of bone invasion noted on imaging, this could influence the extent of resection. If localized, for example, a marginal resection can be done. If more extensive, for example, if more than 25% of the vertical height of the mandibular segment is involved, a segmental mandibulectomy may be required. Here's an example of a carcinoma centered and involving the mandibular symphysis. And one of the points I would like to highlight is that you definitely want to make use of all the imaging planes. For example, the sagittal plane really helps. In this case, as you can see the extent of tumor quite nicely, we can appreciate that tumor extends along the inner margin of the lip and chin as well. It extends onto the floor of mouth and the ventral tongue. This is an example of an extensive angiosarcoma involving the left hemimandible. If you see something like this with overt mandibular infiltration, it really should be almost a reflex for you as a radiologist to ask what is the status of this structure. This is the inferior alveolar nerve, which is a distal branch of V3, and it runs in the mandible and exits as the mental nerve. So here's a normal appearance of the nerve within the mandible. The nerves should be symmetric bilaterally when you assess them. This is the course of the nerve in the masticator space as delineated by the arrows. And here we can see the nerve extending superiorly through foramen ovale into the back of the cavernous sinus. Again, it's always important to pay attention to symmetry between the two sides. So when we see something like this, when we see that there is diffuse infiltration of the mandible, we know that the nerve is totally surrounded by tumor. In this case, you definitely want to trace the nerve back, looking for thickening or enhancement, which would be radiographically suggestive of perineural tumor spread. Here is the nerve on the right side, and here on the left side we can see that there's abnormal thickening and enhancement of the nerve extending grossly to this level within the masticator space. And this is important to document as the clinicians will be able to resect tumor within this compartment up to this level and intraoperatively take frozen sections for assessment of the resection. Okay, how about buccal carcinomas? Here's an obvious large buccal carcinoma as highlighted by the asterisk. For smaller lesions, however, one imaging clue that we can look for is the status of the buccal fat stripe. As you can see here, it should be contiguous. You can see on the right side, this fat stripe is contiguous along the entire length, and on the left side, however, we can see that the fat stripe becomes truncated and that there is replacement by this amorphous or irregular soft tissue in this patient with a small buccal carcinoma on the left side. Again, as we saw earlier, a puffed cheek imaging technique is very helpful for buccal lesions. Again, this would be very difficult to see. This carcinoma would be difficult to evaluate if the tongue was closely applied to the buccal carcinoma, or the buccal mucosa in this case. Here is another example of a buccal carcinoma with no puffed cheek, and then with a subsequent puffed cheek, we can see the tumor more easily as delineated by the arrows. Here is another obvious large buccal mass on the right side. And again, it's always important to remember to make use of the various imaging planes. And for buccal lesions, the coronal plane is very important. One of the things, for example, we want to assess is the status of the upper and lower buccal alveolar sulcus. We want to see if tumor extends to this region, and if so, we need to closely assess the bony jaws. In this case, for example, the upper and lower sulci appear clear. In this example, we actually see that there is extension of this right-sided buccal lesion across the sulcus, reflecting onto the adjacent maxilla with actual bone invasion. So again, puff cheeks and coronal imaging is really important for this assessment. Lateral soft tissue extension is also important in assessment of buccal lesions. Here we can see that there is actually a full thickness invasion of the right cheek, including the skin. This is important to note so the surgeon can plan for the appropriate degree of resection and reconstruction. In this case, they knew that they needed a flap reconstruction, as you can see here. The hard palate is also a part of the oral cavity, and while squamous cell carcinomas can certainly arise in this location, when thinking about palate neoplasms, you have to start thinking also about minor salivary gland tumors such as adenoid cystic carcinomas. And again, the coronal imaging plane, as you can see here, is very important. You want to closely assess for extension of disease into the nasal cavity, for example, or into the adjacent maxilla and bone. You also need to be wary of possible perineural spread of tumor in patients with palate disease, for example, along the palatine nerves. These nerves extend along the palate and then rise up via the greater and lesser palatine foramen to the region of the pterygopalatine ganglion and then back along V2. So here are the normal foramen as outlined by the arrows on both sides. And this is showing you the vertical course of these nerves on both sides. So here's an example. This is a patient with an adenoid cystic carcinoma along the undersurface of the left hard palate, and let's follow the appearance of the nerves in this case. We can see that there is asymmetric enlargement and enhancement of the nerves as they rise up on the left side, following the tip of the arrows. Here we can see extension superiorly. So again, asymmetric enlargement and enhancement of the nerves are direct radiographic imaging features for perineural tumor spread. Here we can see an abnormal blush of soft tissue enhancement in the left pterygopalatine fossa. More proximally, we want to follow the entire course of the nerve as it extends posteriorly along V2. And at this point, we can see that there is thickening and enhancement of left V2, again, in keeping with perineural tumor spread. The same thing now we can see on axial. This is the tumor here as outlined by the arrows. And let's follow the course of the nerves. At this point, we can see abnormal enhancement and widening of the pterygopalatine fossa. And here we can see tumor tracking back along V2. So the contrast-enhanced MRI sequences are really important to assess for perineural tumor spread. Okay, how about the tongue? So for staging of tongue cancer, it is important to tell the clinician the actual portions of the tongue that are involved. For example, is the tumor involving the oral tongue or the base of tongue or both? You want to assess the status of the ipsilateral lingual artery. You also want to assess whether there is extension of tumor across midline, in which case there may be a risk for contralateral lingual artery involvement. So in this example, we see a left oral tongue cancer involving the middle third of the tongue. The base of tongue is clear and there is no extension across midline. I also like to give a tridimensional measurement for the lesion, as that is part of the T category staging. Here's an example of lingual artery involvement. We can see a large right-sided tongue mass that involves the flow void of the lingual artery. We want to assess whether tumor comes to touch or actually encases the vessel. Some more examples: one patient with bilateral lingual artery involvement versus another with one lingual artery involved. So if surgery was to be considered for these patients, you need to know that you need at least one lingual artery to be able to do a hemiglossectomy. For the patient with the bilateral lingual artery invasion, if surgery was to be a part of the plan, it would need to be a total glossectomy. Another thing to watch out for is the lingual artery after treatment, especially post-radiation therapy. You always want to assess and make sure that there is no lingual artery exposure. So let's look at this example here. We can see a large left tongue-based mass that was radiated. And this is the patient's post-therapy scan. Let's follow the arrows showing you the appearance of the lingual artery. So we can see that the tumor mass has decreased in size. There's some necrosis and ulceration. And as we can see on this image, there's actual lingual artery exposure on the left. This is something you want to pick up before the patient develops a potentially catastrophic and life-threatening hemorrhage. We would like to be able to identify this situation before hemorrhage so that it can be addressed endovascularly under a controlled situation. Okay, so a quick word on the 8th TNM staging for oral cavity cancer. As you may know, the concept of depth of invasion is now used in the T category assessment. And the depth of invasion is a histologic concept. So basically, you are meant to draw a perpendicular or plumb line from the adjacent normal basement membrane to the deepest part of the tumor. This, however, is not necessarily the same as tumor thickness. If the tumor is flat, then yes, the depth of invasion would equal the tumor thickness. But if, like in this case, the tumor is exophytic, we can see that the tumor thickness is actually larger than the depth of invasion. And the opposite is true for an ulcerated tumor. In this case, the depth of invasion would actually be larger than the tumor thickness. So when this new concept of depth of invasion came into effect, one of the things that we asked as radiologists is, should we be trying to give a radiographic depth of invasion measurement so as in to be able to help stage according to the new T staging format. If you take a step back, the staging manual actually states that when you stage clinically, you can employ information gathered from the physical examination as well as any imaging performed. So as a portion of the patients may not or cannot undergo surgery, if there is any desire to actually stage using the concept of depth of invasion, that will have to come from imaging. So knowing this, the next question would be, is imaging actually good at assessing depth of invasion? And this is a work from my surgical colleagues. They actually looked at the group of patients who underwent surgery for oral cavity cancer. They compared the histologic depth of invasion with the clinical estimated depth of invasion versus a radiographically measured depth of invasion. And the result was for tumors with actual thickness, for example, tumors with actually more than 5 millimeters of actual thickness, the radiologic depth of invasion correlated quite well with the histologic measurement. So here are a couple of examples. In some patients, you can actually have imaging that actually lets you try and differentiate between depth of invasion versus tumor thickness. However, in reality, most of the time, this type of resolution is not possible, and you're left with measuring what is just a tumor thickness. So here's another example of trying to measure a tumor thickness versus depth of invasion. And now, granted, most of the time it will be very hard to separate out depth of invasion versus tumor thickness on imaging. So knowing that, what we wanted to see was whether a measurement of a radiologic tumor thickness, not radiologic depth of invasion, but whether a radiologic tumor thickness actually correlates well with prognosis, and hence, going forward, would a radiologic tumor thickness be something that can be incorporated into future TNM staging? So we looked at just over 350 patients who underwent surgical resection and found that first, there was good intra and inter-rater reliability or correlation for the assessment of a radiologic tumor thickness, and that there was actually a good correlation between radiologic tumor thickness and pathologic tumor thickness. It also turned out that radiologic tumor thickness was also prognostic to patient survival. So hopefully, with more work by other centers, hopefully to demonstrate a similar finding, it may be something that can be included in future TNM staging classifications. Okay, my last two slides, I just want to end with a quick word on adenopathy and tongue cancer. Now, most tongue tumors will drain along the jugular chain, for example, into level 2, then down the jugular chain, or inferiorly into level 1 and level B, and level 1B, and then posteriorly along the jugular chain. But there is a portion of the tongue, usually the anterior portion of the tongue, that you can see on this diagram that will actually bypass level 2 and level 1 and drain directly into what's called a jugular-omohyoid node, which is typically a low level 3 or level 4 node. As you can see in this example of a patient with a tongue carcinoma, all the levels in the neck are clear except for this low level 3 or level 4 node corresponding to a jugular-digastric node. And I emphasize this because you do not want to fall into the trap of saying, well, all of the levels proximal are clear, so this node, this single solitary node inferiorly must be clear as well. So again, this is a potential pitfall to avoid. And with that, I would like to thank you for listening and your attention.